Let's talk about a very important topic, that is oral cancer. Not only is it important because you can sometimes get a short case of an oral ulcer in your college exams, but in India, this is a very, very common cancer and it is a serious problem as well. Also, there are a lot of MCQs asked in the entrance exams. The first MCQ which has been quite commonly asked is the most common site of oral cancer. So the most common site of oral cancer, you need to know what is the most common site all over the world. All over the world, it is the lip, and in India, if you're asked specifically in India, it is the buccal mucosa. It is the buccal mucosa or the gingivo-buccal sulcus. So please remember these two things. They have been asked quite frequently in the exam. It is carcinoma lip all over the world, and in India it is the buccal mucosa or the gingivo-buccal sulcus. Now, if we talk about the genetics, another thing which you need to know, the most common gene which has been mutated, most common gene mutated in oral cancers is the P53 gene. You know P53 is associated with a lot of cancers, most commonly mutated in oral cancers as well. Now, oral cancers are, if we talk about the pathology of oral cancers, these oral cancers are squamous cell carcinomas. These are squamous cell carcinomas, and squamous cell carcinomas, Dr. Illa has covered that in squamous cell carcinomas, you will see the typical keratin pearls. That is how we identify a squamous cell carcinoma. You will see these keratin pearls, these whorl-like eosinophilic bodies which are there. These are keratin pearls, and more well differentiated the cancer, more would be the amount of keratin pearls there, and less well differentiated or poorly differentiated, these keratin pearls would be missing. Now, there is a particular type of oral cancer which is known as verrucous carcinoma, right? So what is the difference between a traditional oral cancer and verrucous carcinoma? This is what I want you to understand. So a typical oral cancer, you can see it is presenting as an ulcero-proliferative growth. There is an ulcer there and proliferation, an ulcero-proliferative growth. Whereas a verrucous cancer is a slow-growing cancer. It is a slow-growing cancer. It is associated with human papillomavirus, right? This is associated with human papillomavirus, and you need to know that it grows outwards. As you can see in the image, it grows outwards, and there is minimal invasion. So if there is minimal invasion and it is growing outwards, will it have a good prognosis or a bad prognosis? Of course, it is going to have a good prognosis because the invasion is less and you can easily resect it. So it has a good prognosis as compared to the typical ulcer proliferative lesion. It has a good prognosis. And another name for verrucous cancer, this you should know, is known as Ackermann's tumor. This is known as Ackermann's tumor. So this is another name which you should remember for the exam. And if you refer to the module on penile cancer, I have also told you a slow-growing penile cancer which has the same features. Slow-growing, grows outwards, caused by human papillomavirus, and that is known as Buschke-Lowenstein tumor. Right? So verrucous and Buschke-Lowenstein are quite similar in their behavior. Right. So the next thing which we need to talk about the risk factors for oral cancer. And I'm sure all of you are quite aware, you must have seen all the advertisements on the cigarette packets, or when you go for a movie, you see that a clip playing of a patient, of a young boy with oral cancer, right? So the typical risk factors are smoking, alcohol consumption, tobacco chewing is also a risk factor. Another very important risk factor is a sharp, ill-fitting denture. And during my residency, I saw so many such cases of patients who used to get dentures made, but once they got the denture made, they never followed up with the dentist. So this denture kept on hitting at a particular area and causing an ulcer there repeatedly, which ultimately turned malignant. So a sharp, ill-fitting denture is also a significant risk factor for oral cancer. Other risk factors, I've already told you, human papillomavirus Epstein-Barr virus. Epstein-Barr virus you must have read in ENT, gives rise to nasopharyngeal cancers. Gives rise to nasopharyngeal cancers. Right, so poor oral hygiene or oral infections can also give rise to oral carcinoma, right? So these are some of the risk factors for oral cancers. We'll talk about the pre-malignant conditions, but just to tell you, there was a question asked in the AIIMS exam last year where they had asked which is not a risk factor, and they had mentioned smoking, they had mentioned human papillomavirus, they had mentioned Epstein-Barr virus, and they had mentioned vitamin A deficiency. So vitamin A deficiency has no role in oral cancer pathophysiology. Now, if we talk about the pre-malignant conditions for oral cancers, this is a table directly out of Bailey. They've divided it into high-risk conditions, low-risk conditions, and medium-risk conditions. So, if you look at the high-risk conditions, you can see the high-risk conditions are erythroplakia, proliferative varicose leukoplakia, and chronic hyperplastic candidiasis. We'll talk about each one of them in detail. The medium risk are oral submucous fibrosis and syphilitic glossitis. The low risk are oral lichen planus, and in oral lichen planus, it's predominantly the ulcerative oral lichen planus. You have discoid lupus erythematosus and discoid keratosis congenita. So these are the low risk conditions. Now let's talk about each one in detail. The first one which I want to talk about is leukoplakia. Now leukoplakia, this one, so first thing is you need to identify the image of leukoplakia versus candidiasis, and it can sometimes be confusing, so that's why I've put both the images together. In the recent exams, you're seeing that more and more images are being asked, and these common images you should be able to identify, these spotters you should be able to identify. Now, leukoplakia you can see here is a whitish patch. Leukoplakia is a white patch which cannot be described by any other condition, and it cannot be rubbed off. And it cannot be rubbed off. So sometimes you're asked the definition. So that is the definition. It is a white patch which cannot be explained or characterized by any other condition, and it cannot be rubbed off. Candidiasis, on the other hand, you can see this whitish candidiasis, but then it is surrounded by an erythematous border. There is an erythematous border outside the lesions. And another thing with candidiasis is it can be rubbed off. It can be rubbed off, unlike leukoplakia. So that is how you differentiate the two conditions. Now leukoplakia, you know, is a pre-malignant condition, and it increases the risk of cancer by 3 to 5 times. It increases the risk of cancer. Right, so increases the risk of cancer by 3 to 5 times. This you should know. Now, if it's just leukoplakia, the traditional management of leukoplakia is you put the patient on antioxidants, put the patients on antioxidants. You stop the risk factor. If the patient has been smoking, you stop smoking or stop tobacco chewing, so that constant irritation or insult is not there. If it persists, then we can do a CO2 laser excision, or it can be excised using a cautery as well, and the tissue can be sent for histopathology, right? Now, in leukoplakia, there are two things which I want you to know here. The first one which I want you to know, two types of leukoplakia which have been mentioned in Bailey. So, the first one is proliferative varicose leukoplakia, Now, proliferative varicose leukoplakia is usually seen in those patients. These patients don't exhibit typical risk factors, of oral cancers, and it is usually multifocal. This proliferative varicose leukoplakia is usually multifocal in nature, and there is an increased risk of cancer conversion, increased risk of cancer in these patients in proliferative varicose leukoplakia. Almost 50% you have malignant conversion risk. So 50% conversion risk into malignancy is there. And these patients with proliferative varicose leukoplakia, you should not wait in these patients. The management for these patients is excision. The management is excision. You can try follow up for some time, but if the patient is showing features where it is increasing in size, it is better to excise these lesions. It is always safer to excise these lesions, proliferative varicose leukoplakia. The other one is speckled leukoplakia. The other one is speckled leukoplakia. And speckled leukoplakia is leukoplakia over an erythematous border. Leukoplakia over erythematous border. That is speckled leukoplakia, and this has the highest risk of malignant conversion. Highest risk of malignant conversion is there in this condition. And in these patients, again, the management is excision of the lesion. So either this can be excision using a CO2 laser, or you can just use a traditional cautery and excise the lesion and send it for histopathology. So this is a patient where you can see speckled leukoplakia, where you can see it's an erythematous border, and then you can see the leukoplakia here. This is the erythematous border, and you can see leukoplakia. So these patients, it should be excised. Now the other condition which we need to talk about is erythroplakia. Erythroplakia, like leukoplakia, it is a red patch which cannot be rubbed off. So leukoplakia was a white patch, erythroplakia is a red patch which cannot be characterized by any other condition, and it cannot be rubbed off. And it cannot be rubbed off. That is an erythroplakia. And erythroplakia increases the risk of malignancy by 6 to 9 times. So leukoplakia was 3 to 5 times, erythroplakia, the risk of malignancy is 6 to 9 times, and in erythroplakia the management is excision. You excise these lesions and you send the tissue for histopathology to rule out that if there is no non-invasive or invasive cancer present there. The most aggressive one, again, like leukoplakia, you had speckled leukoplakia, which was the most aggressive. The most aggressive erythroplakia is speckled erythroplakia. Now, if you are asked an MCQ, which is the most likely to undergo malignant conversion, and if the options are leukoplakia, erythroplakia, speckled leukoplakia, speckled erythroplakia, which one will you mark? So I have told you erythroplakia has a higher risk of malignant conversion, and amongst that the most aggressive is speckled erythroplakia. So the highest risk of malignant conversion would be with speckled erythroplakia. This you need to remember. Chronic hyperplastic candidiasis, I have already pointed out to you, is also a risk factor for oral cancers. Another one very important for your exam is oral submucous fibrosis. Oral submucous fibrosis is commonly seen in the Indian subcontinent, and it is a hypersensitivity reaction. It is a hypersensitivity reaction to the products of betel nut. To the products of betel nut. So patients who are prone to this condition, what they develop is there is fibrous deposition in the oral cavity. There is fibrous deposition in the oral cavity. And you can see here, you can see the fibrous deposition. You can see all this whitish is fibrous deposition. And this fibrous deposition, what does it lead to? If you have fibrous deposition at the angle of the mouth is not going to open up. See here, there is going to be inadequate mouth opening. There's going to be inadequate mouth opening, and if there is inadequate mouth opening, what is that going to lead to? That is going to lead to poor oral hygiene. As it is, these patients who chew tobacco or smoke, they don't maintain a very good hygiene, right? Some of them sleep with a betel quid in the mouth, right? But if there's inadequate mouth opening, there's going to be further poor oral hygiene, And because of this poor oral hygiene, there is going to be increased risk of cancer in these patients. There is going to be increased risk of cancer in these patients, and these patients you can routinely see in your OPDs. If you go to the surgery OPD or the ENT OPD, you can routinely see these patients. The management. Now, you would think it is very easy. If there is inadequate mouth opening due to fibrous deposition, just cut the fibers and the mouth opening would be adequate then, right? But you need to understand that if I cut the fibrous tissue, how does the body heal? The body heals by deposition of more fibrous tissue. So the more amount you cut, more and more fibrous tissue will get deposited, and it will in fact worsen the condition. So the management in these patients is to ask the patient to stop smoking or tobacco chewing. You need to give these patients antioxidants, but the mainstay of treatment is intralesional triamcinolone. Triamcinolone, if you remember, is a steroid which we've discussed. Where else is intralesional triamcinolone used? We've also discussed that intralesional triamcinolone is used for keloids. It is used for costochondritis, which we discussed in the breast module, and it is used for ganglions as well, right? And the fourth one I've just told you, it is also used in patients with oral submucous fibrosis, right? So this is the management of a patient with oral submucous fibrosis. The other premalignant conditions I've already highlighted. One which deserves special mention is Plummer-Vinson syndrome. Plummer-Vinson syndrome is also known as Patterson-Kelly-Brown syndrome. This has been asked many times in the exam. Patterson-Kelly-Brown syndrome, also known as sideropenic dysphagia. Now, this Patterson-Kelly-Brown syndrome or sideropenic dysphagia is typically seen in perimenopausal women. It is seen in perimenopausal women. And what will be the clinical features in these patients? The clinical features, patients are going to have koilonychia. Koilonychia, you know, are spoon-shaped nails. Spoon-shaped nails are going to be there. There's going to be iron deficiency anemia, right? So there's going to be iron deficiency anemia, glossitis, and angular cheilitis. Right, so these are the typical features which you get in a lady. In addition to this, there are post-cricoid webs. This is something which has been asked many times in the exam. There are post-cricoid webs seen in these patients. So these post-cricoid webs, what are they going to give rise to? If you have a web beyond the cricoid, this can give rise to dysphagia. So these patients also have dysphagia. It is also one of the causes of dysphagia which can be seen in these patients, right? So the management of these patients, correct the anemia. You have to deal with the web. If it is there, you can deal with the web either by dilatation or by laser excision of that web. Either one can be done. But you need to know that this condition increases the risk of two cancers. Both the cancers have been asked in the exam. It increases the risk of squamous cell carcinoma of the esophagus. This I have highlighted when I was enlisting the risk factors of carcinoma esophagus as well. And it increases the risk of hypopharyngeal cancer. This has been asked in the AIIMS exam. And it increases the risk of hypopharyngeal cancer as well. So these are the various premalignant conditions which you should know in oral cancers. And a lot of questions have been asked from these premalignant conditions. Now, one thing which I want to tell you which is very important, and I have highlighted this in the module on colorectal cancers and bladder as well, the term is known as field cancerization. The term is known as field cancerization. This is a very important term for the exam. Now, field cancerization basically means that all these risk factors which are there, they are acting on the entire oral mucosa, right? So, when they act on the entire oral mucosa, there can be multiple tumors arising in that area. So, multiple tumors can arise in this area, and this phenomena of field cancerization we've discussed can be seen in the oral cavity, can be seen in the bladder, and it can be seen in colorectal cancers, colorectal region. Now, if you remember colorectal, I told you that 4% patients have synchronous tumors, right? That is why we need to do an entire colonoscopy to see the entire colon, just in case we don't miss out on a synchronous lesion. Similarly, bladder, you can have multiple tumors in the same go. In the oral cavity also, you can have multiple tumors arising, and there are two terms which you need to know. One is a synchronous cancer. And the other one is a metachronous cancer. So, synchronous cancers are cancers which develop within 6 months of the initial tumor. So, within 6 months of the initial tumor, if you develop another tumor in the same region, that is known as a synchronous malignancy. Metachronous is when it develops more than 6 months. After 6 months, that is a metachronous tumor if it is developing in a similar site after 6 months. And the risk of metachronous cancers in oral cavity is almost 15%. So, if somebody has had an oral cancer, there is a 15% risk of another cancer arising after 6 months or so in the oral cavity. This you should know. And I just want to give you an example of a lady which we followed up right throughout my residency. So, when I joined as a first year resident, there was this girl who had come. She was 28, and ladies might be able to correlate with this better. She used to do threading in a parlor, and to do threading, they put this thread inside their mouth. One end of the thread is inside their mouth, and then they use their finger to do this threading and remove the hair. Now, because of that constant trauma, she developed an oral cancer in the tongue, right? So, initially it was a small lesion. We did a partial glossectomy for her, and she was fine. She still kept on working. She was the sole earning member of her house. But because she kept on working, again there was more trauma, and she again landed up 8 months later with another lesion in the tongue, and this time she had to undergo a hemiglossectomy and a flap had to be put, and this altered her speech, and she had difficulty working after that as well. So this is just one thing which I want to highlight, that multiple tumors can arise in this region. We've discussed the pathology, we've discussed the risk factors and the pre-malignant conditions. Now, how do we work up a patient with oral cancer? I've already shared a video of a case of an oral ulcer, and I've told you about the examination points which are important. Now, once you've taken the history, once you've done the examination, we need to confirm the diagnosis. So, this is our patient, and like I discussed in any case presentation, whenever you are asked, you should always say, I will do investigation to confirm the diagnosis here. So, how do we confirm the diagnosis in such a patient, or what is the investigation of choice in such a patient? Of course, it's a biopsy, right? So, it's going to be a biopsy. The second question which I want to ask you is incisional or excisional. This also I have told you. Excisional means if we remove the entire tumor. Incisional means if I just remove part of the tumor to confirm the diagnosis. So, here I am going to just remove a part of the tumor. So, I am going to do an incisional biopsy. And this is a very common question asked in the exam. Where will you do the biopsy from? So, in such a patient, we will always do the biopsy from the edge of the ulcer. Please remember, biopsy will be taken from the edge of the ulcer, never from the center. We will not take it from the center because the center is necrotic, right? This is what they want to hear in the viva. So, we will take an edge or a wedge biopsy. Edge or a wedge biopsy would be taken. Now, another thing which I want to tell you here, this is another question which you are asked in the viva, that supposing you take an edge biopsy and it turns out to be inconclusive. The pathologist says it's inconclusive. So sometimes what happens is that these patients with oral cancers also have super added infection, and the biopsy might not be representative. So if you get an inconclusive biopsy, what do? Inconclusive biopsy, you start the patient. So if you get an inconclusive biopsy, give antibiotics for 7 days, give antibiotics for 7 days and repeat the biopsy. And you repeat the biopsy. This will take care of the superadded infection and you can then reach to the diagnosis. So this is how we confirm the diagnosis. Now once we've confirmed the diagnosis, the next thing is I want to know where all has the cancer spread. So what is the investigation of choice to stage the disease? So the investigation of choice to stage oral cancers is a CECT, PNS and thorax, right? So CECT, PNS, neck and thorax. So contrast and CT scan of the paranasal sinuses, neck and thorax is what we do to confirm the stage of the patient where all has the cancer spread. Now this brings us to the staging of oral cancers, which is very important. It has been asked multiple times in the exam. So first I'm going to tell you about the 7th TNM staging, and then I'll tell you the updates in the 8th HSCC classification. This 7th TNM staging you need to remember, and then just the updates, okay? So the first thing, you know that for cancer staging we have the TNM classification. T is for tumor, N is for nodes, M is for metastasis, right? So first we'll talk about T stage. So TX is something which I want you to understand. When the tumor cannot be assessed, tumor cannot be assessed. So what are the situations when you can't assess the tumor? One is if surgery has already been done, or two, if the patient has received neoadjuvant therapy, that means therapy before surgery, chemo or radiation, or if supposing the patient is unable to open his mouth only. It's such a big tumor, patient is unable to open his mouth, so you can't assess the extent of the tumor. So you'll write it as TX, tumor cannot be assessed. TIS is in situ cancer, T1 is less than equal to 2 centimeters, T2 is 2 to 4 centimeters, T3 is more than 4 centimeters, T4 is something which I want you to remember. T4 is involvement of adjacent structures. You can have T4A is involvement of adjacent structures, which can be resected, and T4B is involvement of adjacent structures which cannot be resected. Adjacent structures which cannot be resected. So let me give you an example of both of these, right? So one patient has a tongue cancer, but this tongue cancer is now involving the mandible, right? The tongue cancer is involving the mandible. Mandible I can resect, right? So it's an adjacent structure, but I can resect it, so that is T4A. But there is another patient who has a buccal mucosal cancer, and now it is involving the pterygoid muscles or the base of the skull. So if it involves the pterygoid muscles or the base of the skull, cannot resect it, right? So resection is very difficult there. That becomes T4B. So that is how we differentiate. So what would be, let me just give you some examples. So if you get an MCQ, what would be the T4B areas? So this would be base of skull. This would be base of skull, RMT, retromolar trigone. You have the carotid vessels. Carotid vessels also, if they are involved, then surgery is difficult, okay? So these are the things which you need to remember in the T staging of oral cancers, right? Moving on to the nodal staging. Nodal staging is very important. Before I tell you about the nodal staging, you can make a note here of the 8th AJCC update in T stage. So the 8th AJCC update in T stage is that depth of invasion, DOI is depth of invasion, has been added as an independent risk factor. This is now an independent risk factor for oral cancers. Independent prognostic factor for the T stage. This is an independent prognostic factor for T stage. This you should know. This is the 8th AJCC update, okay? The nodal staging is very important for the exam. So NX again would be when the nodal stage cannot be assessed. NX is when you cannot assess the nodes. N0 is when no nodes are involved. N1 is a single ipsilateral lymph node. It is a single ipsilateral lymph node on the same side, less than equal to 3 centimeters in size. Less than equal to 3 centimeters in size. N2 is divided into N2A, N2B and N2C. N2A is a single ipsilateral lymph node, 3 to 6 centimeters in size. 3 to 6 centimeters in size. N2B is multiple ipsilateral lymph nodes. Multiple ipsilateral lymph nodes, less than equal to 6 centimeters in size. And N2C is bilateral or contralateral lymph nodes, less than equal to 6 centimeters in size. So this you need to remember, and this brings me to another very important point which is asked both in the Viva and in the MCQ exam, that which are the tumors which can give rise to tumors which have a propensity for bilateral lymph node involvement. Propensity for bilateral lymph node involvement in the cervical region. So this would be angle of mouth tumors, angle of mouth tumors, tip of the tongue tumors, tip of tongue tumors, lip cancer crossing midline, lip cancer crossing the midline, and soft palate. And soft palate cancer, right? So these are the cancers which can give rise to bilateral lymph node involvement. This you should know for the exam, right? Finally, you have N3. N3 is any lymph node mass more than 6 centimeters in size. Now, what is the 8th AJCC update which you need to know? The 8th AJCC update is the 8th AJCC update for nodal staging is ENE, extranodal extension. ENE is extranodal extension, has been added. Extranodal extension has been added as an independent prognostic factor. This is an independent prognostic factor for oral cancers, and if ENE is positive, extranodal extension is positive, whether clinically or radiologically, this is going to become as N3B disease. Right, so now N3 has been further subdivided. Look here please, N3 has been further subdivided. N3A is any lymph node mass which is more than 6 centimeters but no ENE, but no extranodal extension. And N3B is ENE present. I've already told you whether clinical or radiological, and irrespective of the size, this is going to become N3B. Whether even if the lymph node is 2 centimeters, but there is ENE, it becomes N3B. So let me give you an example. There was a patient which we got, he was a 48-year-old patient, and he came with a very small lesion on the lateral border of the tongue on the left side. the lesion was 1 into 1 centimeters. But he had a 2 centimeter lymph node in level 2 on the left side, and this was fixed to the skin. This lymph node was fixed to the skin. So how will the lymph node become fixed to the skin? Only if the tumor goes out of the lymph node. So there is extranodal extension. So even if the lymph node was 2 centimeters, but there was extranodal extension because of fixity, it becomes an N3B disease according to the latest AJCC classification. Please remember this point, this is important. MX is when distant mets cannot be assessed. M0 is no distant mets. And M1 is the presence of distant metastasis. And the most common site, this has also been asked in the exam, the most common site for distant metastasis from oral cancers are the lungs. So lungs are the most common site which are affected from oral cancers as distant metastasis. This you should remember for the exam. So this was regarding the TNM staging. You need to memorize this. TNM staging for oral cancers and breast cancers are asked quite frequently. They are favorite topics of the Central Institute exams, and now with the INI CET coming up, one staging question will invariably be there. Another 8th AJCC update is there is a new category of tumors. There is a new category of tumors. These are HPV positive, P16 positive tumors. Right. So new category has been added in the 8th AJCC classification, HPV positive, P16 positive lesions. So we've discussed how to make the diagnosis, how to stage the disease. We've discussed the TNM staging as well. Now we move on to the management of oral cancers, right? So the management of oral cancers, there are 3 modalities to manage oral cancers. You have surgery, there is chemotherapy, and there is radiotherapy. Now, surgery for oral cancers, there are 4 aspects in the surgical management of oral cancers. Number 1, you have wide local excision. You have wide local excision of the primary lesion. Of the primary tumor, we have to excise it using wide local excision. WLE is wide local excision. Okay. Now, one thing which I want you to remember, that the old margin status. So, whenever I excise a tumor, you know I want an R0 resection. We've discussed this multiple times. R0 is when I have microscopic freedom from disease, when the entire tumor has been removed. So, when I remove the tumor, I always take a margin. Now, earlier, the old margin status for oral cancers was 2 centimeters. But nowadays, surgeons are becoming less aggressive, becoming more conservative in their approach. So, the latest margin status is 0.5 centimeters. Is 0.5 centimeters, that much is enough in oral cancers. The second aspect is, if the lymph nodes are involved, then we will do a neck dissection, and neck dissection is something which I will cover in detail towards the end of this module. I'll tell you about neck dissection. That is also a very, very important topic. We'll cover it in detail. If mandible is involved, if the mandible is involved, then we need to do mandibular resection. Then we have to do some kind of mandibulectomy, and mandibulectomy can be of 3 types. You can either end up doing a segmental mandibulectomy, you can do a hemimandibulectomy, or you can do a marginal mandibulectomy. These are the 3 types of mandibulectomies which can be done. Segmental mandibulectomy, as the name suggests, I am just removing a segment of the mandible. So, if this is the mandible and supposing just this much portion is affected with cancer, then I can remove this segment. Right, I will just remove this much segment of the mandible. That would be known as segmental mandibulectomy. If a small segment is removed, that is segmental mandibulectomy. Hemimandibulectomy, as the name suggests, if I remove half the mandible, that is hemimandibulectomy. Right, quite a morbid procedure, and you need to reconstruct with a flap. Marginal mandibulectomy, you need to know that there is an inner table This is the inner table and this is the outer table of the mandible. This is the outer table of the mandible, right? Now, supposing we have a cancer which is just involving the inner table of the mandible, then I can just shave the inner table. I can just shave out the inner table. If these are the two tables, inner table is involved, just shave out the inner table and leave the outer table intact. That is a marginal mandibulectomy. So, these are the three types of mandibulectomies which can be performed in oral cancer if the mandible is involved. Now, very important for the exam, what you need to know is that if you do a wide local excision, lymph node dissection or neck dissection and mandibulectomy, 1, 2, 3 steps combined, this is known as commando procedure. This is known as commando procedure and it has been asked many times in the exam. One of the reasons why it is known as commandos procedure is because the procedure lasts for around 7 to 8 hours, and like commandos you need to stand there in the theatre for 7 to 8 hours. And my professor whom I used to work a lot with used to do a lot of oral cancer surgeries, and almost once a week we used to stand for 7 to 8 hours washed up in a commando procedure. So, these are the three aspects of commando. Once you've done all the excision, once you've chopped off the cancer and the other lymph nodes, finally you need to reconstruct the defects as well. So, the fourth aspect of oral cancer surgery is the reconstruction. And reconstruction is done using flaps. I've already discussed all these flaps in detail in the plastic surgery module, but just to recapitulate the flaps used for oral cancer quickly. So, this was an actual patient which I saw during my residency where we had done bilateral deltopectoral flap. So, this one is a deltopectoral flap. This I have told you, deltopectoral flap. And deltopectoral flap, you know, are based on the perforators of internal mammary artery. Based on the perforators of internal mammary artery. The other flap, this is the workhorse of a head and neck surgeon. This is the PMMC flap, pectoralis major myocutaneous flap, PMMC flap, pectoralis major myocutaneous flap. This is the most commonly used flap by a head and neck surgeon. This is the most commonly used flap by a head and neck surgeon. This question has been asked multiple times, and this is based on the pectoral branch of thoracoacromial vessels. This is based on the pectoral branch of the thoracoacromial vessels. Okay. The other flaps which can be used to cover the oral cancer defects, you have Abbe-Islander flap. Abbe-Islander flap is known as a lip switch flap. You can see the image here, and I've highlighted in the plastic surgery module that Abbe flap is used for midline defects, whereas Islander is used for angle of mouth reconstruction. Abbe is used for midline, Islander is used for angle of mouth. You can also have a circumoral advancement flap, for lip reconstruction, and this also I have covered in plastic surgery. This is known as the Karpendasik flap, right? So, you have the Karpendasik flap, which is a circumoral advancement flap for lip reconstruction. I also told you about free flaps used for oral cancer reconstruction. This is a radial artery forearm flap, and this one is a free fibular flap. Free fibular flap, you know, is based on the peroneal vessels. This is based on the peroneal vessels, and this is the most commonly used flap. We are going to get a fibula, and this is the most commonly used flap for mandibular reconstruction. For mandibular reconstruction, this question has been asked many times in the exam, so you should know about it. This is the most commonly used for mandibular reconstruction. And if I have to be precise, this is used for patients with edentulous mandible. This is used for patients with edentulous mandibles, the free fibular flap. But if you have a patient with a dentate mandible, then in that case we will use the deep circumflex iliac artery flap or the iliac crest flap. So we use the iliac crest flap in this case, and this is based on the deep circumflex iliac artery. This is based on the deep circumflex iliac artery. This is the iliac crest flap. So you should know the difference between dentate and edentulous mandible, which flap is to be used. Now, before we talk about neck dissection, let's talk about site-specific tumors and their local surgery which is performed. Now, let's talk about lip cancer first. You know, lip is the most common site of oral cancer. So if you have a lip cancer which is involving less than 1/3 of the area, if it is involving less than 1/3 area, then we can do resection and primary closure, right? So look here, if the lip cancer is just involving a small portion, I can excise that and I can close it primarily. And when I close it primarily, there's going to be no microstomia, right? Because it's a small defect, it won't lead to microstomia. But if the defect is more than 1/3 to 2/3 area, more than 1/3 to 2/3 area, if it's this much defect and if I close it, then what is going to happen? It's going to give rise to microstomia, right? The opening would be narrowed. So in this case, we have to use a Johansson stepladder approach. This is known as the Johansson's stepladder approach, which is a type of an approach which can resect a larger area of lip without leading to microstomia. Now, if you have a patient where more than 2/3 of the area is involved, then we will have to use a flap like the Abbe-Eslander flap or a Carpendasic flap, which I have already explained to you previously. We will use an Abbe-Eslander or a Carpendasic flap to cover up the defect. Buccal mucosa is the most common cancer in India, and for buccal mucosal tumors, wide local excision followed by flap reconstruction needs to be done, that is the surgery, followed by flap reconstruction needs to be done. Now, buccal mucosal, what are the various approaches to buccal mucosa? So the approaches are, I can either go intraoral, right, through the oral cavity, and I can resect the tumor. This is pretty doable for such a cancer where you can see it's very close to the angle of the mouth and it's anteriorly placed, and we can resect it this way. But supposing you have a posteriorly placed buccal mucosal tumor, in that case you'll need to do a lip split approach. So lip split approach is when you split up the lip and you can approach these posteriorly placed buccal mucosal tumors. That can be done using the lip split approach. There are two more approaches which have been mentioned in Bailey, so I want you to know about them. One is the visor approach, where you lift all the structures up like a visor, and this gives you good access to mandible and the floor of the mouth. Mandible and floor of mouth, you can easily operate using the visor approach. And there is one more approach which has been mentioned. This is the Weber-Ferguson approach. This must have been covered in ENT. This is used for maxillectomy. Because the diagram was there in Bailey, so I have just included this. This is for maxillectomy. So this was regarding buccal mucosal tumor. For hard palate, if you have a tumor, we have to carry out wide local excision for a hard palate tumor. But one thing which you need to remember in a hard palate tumor is the very high risk of oroantral fistula, right? And I'll just share a very personal experience here. There was a neighbor of mine, she was postmenopausal, and earlier on she used to chew tobacco, and then she had a denture placed, and this denture wasn't placed very well, and because of recurrent trauma she developed a hard palate lesion. So one of my friends who's an oncosurgeon operated her, and because it was going right up till the bone, the periosteum also had to be removed. And within 3 months, she developed an oroantral fistula. And how do you know that the patient has developed an oroantral fistula? They gave me a call and said that whatever I'm eating or whatever I'm drinking is coming out through the nose. So that's a telltale sign of an oroantral fistula, that food or water or liquids, whatever they have, will come out through the nose. And if an oroantral fistula develops, then we have to do a flap closure here. Okay. So this was the site-specific approach to oral cancers. Now, before we talk about neck dissection in detail, let me just cover about chemotherapy and radiotherapy for oral cancers as well. I told you the other two options are chemo and radio. First option was surgery, then chemo and radio are there. Chemotherapy is 5-fluorouracil and cisplatin based chemo, and chemotherapy is given in lymph node positive tumors. Chemotherapy is given in lymph node positive tumors. Radiotherapy helps in reducing the loco-regional recurrence rate. LRR is loco-regional recurrence rate. And radiotherapy can either be external beam radiotherapy. EBRT is external beam radiotherapy. That means the rays are coming from outside, or it can be brachytherapy. Brachytherapy I have covered at various areas. I have covered it in rectum, I have covered it in prostate and in breast as well. Brachytherapy is when the electrodes are directly implanted at that site. That is brachytherapy. Nowadays, what is happening, that combined chemoradiation is being used. Combined chemo RT is being used. And what is the advantage of combined chemoradiation? It has better response rates. When both are combined, better response rates are being seen. And the chemo drugs, the chemo is acting as a radiosensitizer. It is making the tissue more responsive to radiotherapy. So the chemotherapy drugs are acting as a radiosensitizer. This also you should know. And for advanced tumors, if you have advanced tumors, then neoadjuvant chemoradiation is being used. Neoadjuvant chemoradiation is being used. And this helps in shrinking the tumor, and then we can do the surgery easily. Now, before I talk about neck dissection, two more points which I want you to know. One is that the most important prognostic factor for oral cancers, the most important prognostic factor for oral cancers is the cervical lymph node status. Is the cervical lymph node status. This has been asked many times in the exam. And the second point, which I've already highlighted, the most common site of distant metastasis from oral cancer is to the lungs. The most common site of distant mets is to the lungs. Now let's talk about neck dissection. Before we talk about neck dissection, we need to know the anatomy of the lymph nodes of the neck. Now this has been covered in the anatomy module, but just to quickly go through it, I'll make this diagram a very simple diagram, and you can utilize this diagram for your college exams, and also if you get an MCQ, you can quickly make this diagram and answer most of the questions pertaining to neck dissection. So first let's label the bony landmarks. You have the mandible, you have the mastoid process, you have the clavicle, and you have the hyoid bone, right? So this is the mandible, this is the mastoid, this is hyoid, and this is clavicle. Okay, these are the bony landmarks which are there. Let's draw the muscles as well. You have the anterior belly of digastric, you have the posterior belly of digastric. So this one is anterior digastric, this one is posterior digastric. Then you have the sternocleidomastoid, going from the mastoid to the clavicle. This is your sternocleidomastoid. You have the superior belly of omohyoid. This is superior omohyoid. And you have inferior omohyoid. And you have the trapezius. And you have the trapezius. So these are the muscles which are there. The bony landmarks and the muscles I've highlighted. I'm just going to rub them off now, and then we'll talk about the individual lymph node groups. Now you all know that there is an anterior triangle in the neck and there is a posterior triangle in the neck, okay? So the anterior triangle is bounded by the imaginary midline, the sternocleidomastoid and the mandible. Midline, sternocleidomastoid, mandible. And the posterior triangle is bounded by the sternocleidomastoid, the clavicle and the trapezius. That is the posterior triangle, okay? Now let's divide the anterior triangle into further smaller triangles. The first triangle which you need to know about is the submental triangle, right? This is the submental triangle, and as you can see here, the submental triangle is bounded by the midline, the imaginary midline, the anterior belly of digastric and the hyoid bone, and the lymph nodes which are there are the 1A or the submental group of lymph nodes. The level 1A or submental lymph nodes are present in the submental triangle. The next lymph node group and the next triangle, this has been covered in anatomy as well by Dr. Raviraj. This is the digastric triangle. Digastric triangle, as the name suggests, is bounded by the two digastrics, the anterior belly of digastric, posterior belly of digastric and the mandible. So this is your digastric triangle, also known as the submandibular triangle, and you have the level 1B or the submandibular group of lymph nodes. Here 1B or submandibular group of lymph nodes will be present in this triangle. Another point which I've covered in salivary glands, how do we differentiate submandibular lymph nodes from a submandibular salivary gland enlargement? Correct, we do it by bimanual palpation. An enlarged gland can be bimanually palpable, but a lymph node in this region will not be bimanually palpable. The next thing is to divide the sternocleidomastoid into 3 equal halves. We start from the mastoid to the upper border of hyoid, upper border of hyoid to omohyoid, and omohyoid to clavicle, right? So this upper 1/3, that is from mastoid to hyoid, these are level 2 lymph nodes. From hyoid to omohyoid, level 3 lymph nodes, and the lower 1/3, that is omohyoid to clavicle, are level 4 lymph nodes. Level 2, 3, 4 are all in the anterior triangle, and 2 is upper deep cervical, 2 is upper deep cervical, 3 is middle deep cervical, and 4 is lower deep cervical. So these are level 2, 3, 4, they are also in the anterior triangle. Now level 5 are posterior triangle lymph nodes, level 5 are posterior triangle lymph nodes. As you can see here, this is the largest group of lymph nodes as well, level 5 of posterior triangle. And you have level 6 lymph nodes then. Level 6 lymph nodes are the central compartment lymph nodes. Another name for them are pre or paratracheal lymph nodes. And another name which has been asked in the exam, it has been mentioned in Bailey as well. These are also known as the Delphian lymph nodes. Now central compartment lymph nodes, you need to know the extent, it has been asked in the exam. So the extent of central compartment lymph nodes, you can see superiorly, it is the hyoid bone. Hyoid bone superiorly, you have the suprasternal notch. You have the suprasternal notch inferiorly, right? And you have the carotid sheaths on both the sides. You have carotid sheath on both the sides laterally. This is the extent of the central compartment, and you need to know the 2 cancers which first go to the central compartment lymph nodes. This question has also been asked. You have thyroid cancer and laryngeal cancer. These are the 2 cancers which first drain to level 6 lymph nodes. Level 6 lymph nodes. This question has also been asked in the exam. Right, level 7 are the mediastinal lymph nodes. So this is regarding the lymph nodes of the neck. You can see here that this is just a labeled diagram, and you can see 1A, 1B, 1A, I'll repeat, submental, 1B is submandibular, 2 is sometimes divided into 2A and 2B. Then you have upper deep cervical, middle deep cervical, lower deep cervical. Level 5 are the posterior triangle. Again, you can see here that by the omohyoid, the posterior triangle superiorly is 5A, inferior to omohyoid is 5B. Level 6 is central compartment lymph nodes. So this is regarding the lymph nodes of the neck. Now let's talk about neck dissection. So neck dissection, the first thing which you need to know, the incision for neck dissection is the modified Schubinger's incision. This is the modified Schubinger's incision which is used for neck dissection. This has been asked in the exam, and you can see here the modified Schubinger incision has a horizontal and a vertical limb. We make this incision and then we carry out the neck dissection. Now, what are the various types of neck dissections which are there? This is a favorite question of the Central Institute exams. Every year in the Central Institute, neck dissection, some question related to this is asked in the exam. So, you can have radical neck dissection. Radical neck dissection can be there. Now, radical neck dissection or RND was the first one which was started, and this was described by Kreil. Kreil was the surgeon who described radical neck dissection. And Kreil in radical neck dissection removed level 1 to level 5 lymph nodes, level 1 to level 5 lymph nodes, plus 3 extra lymphatic structures. Plus 3 extra lymphatic structures were removed. And what were these 3 extra lymphatic structures which were removed? Internal jugular vein, spinal accessory nerve, and the sternocleidomastoid muscle. So, internal jugular vein, spinal accessory nerve, and the sternocleidomastoid. So, level 1 to level 5 lymph nodes plus 3 extra lymphatic structures makes it radical neck dissection, and you can see it's a very morbid procedure. Once you remove the sternocleidomastoid, you remove the spinal accessory nerve, patient is going to have shoulder dysfunction. So, this was quite a morbid procedure, which is why the modification came, that is MRND. MRND is modified radical neck dissection. So, what they realized in modified radical neck dissection was that even if you save these structures, the oncological outcome was not affected, right? Even if I save the internal jugular vein or the sternocleidomastoid or the spinal accessory nerve, it doesn't affect the cancer outcome, okay? So, modified radical neck dissection involves the removal of level 1 to level 5 lymph nodes, but we save at least 1 extra lymphatic structure. But we save at least 1 extra lymphatic structure, and that makes it modified radical neck dissection. Okay. Now, modified radical neck dissection, you can have MRND 1. MRND 1 is when the spinal accessory nerve is saved. MRND 2 can be when spinal accessory and IJV are saved, and MRND 3 is when all 3 are saved. Now, if we save all 3 structures, that is, we do an MRND 3, this is also known as a functional neck dissection. If all 3 structures are saved, we will also call it a functional neck dissection, right? Because we are preserving the function as well. So, this is functional neck dissection, right? So, this you should know. One more thing which I want you to know, whether we do an MRND or RND, there are certain other structures which are removed. So, submandibular gland, so the submandibular gland and the tail of parotid, and the tail of parotid can also be removed. And there was a question which was asked in the AIIMS exam last year, They had asked which structure is not removed in modified radical neck dissection or neck dissection, and the options given were tail of parotid, submandibular gland, sublingual gland, and they had given one more option. So we don't remove the sublingual gland, but the submandibular gland and the tail of parotid can be removed in neck dissection. Now you can have selective neck dissection as well. SND is selective neck dissection, and selective neck dissection you can have central neck dissection. You can have central neck dissection. Central neck dissection will only be level 6 lymph nodes are removed, and this you know we've discussed in the thyroid module. This is usually done in patients with thyroid cancers if only the level 6 lymph nodes are enlarged. This is CND or central neck dissection. You can have SOHND. SOHND is supraomohyoid. Is supraomohyoid neck dissection. Now if you look at the diagram, let's see which all lymph nodes do we need to remove in supraomohyoid neck dissection. Okay. Now we know this is the superior belly of omohyoid, right? And you can see which all lymph node groups come above this. You have 1, 2 and 3. So if we remove level 1, 2, 3, that becomes supraomohyoid neck dissection. So SOHND is 1, 2, 3 lymph node levels are removed. And if you want to do an extended SOHND, extended would be 1 to 4 lymph node levels will be removed. So this is selective neck dissection. This also you should know for the exam. So these are the various types of neck dissections which you should know. You should also know about the complications of neck dissections. They've been asked quite frequently in the exam. So the complications of neck dissection, number 1, of course, there can be hemorrhage. There can be injury to the nerves, and these injury to the nerves are what has been asked most frequently in the exam. Now, the first one is marginal mandibular nerve. Marginal mandibular nerve, right? Marginal mandibular nerve is also known as the ramus mandibularis. Marginal mandibular nerve is also known as the ramus mandibularis, and this is a branch of the facial nerve which supplies the angle of mouth. It supplies angle of mouth, right? So if this nerve is injured, if the ramus mandibularis or marginal mandibular nerve is injured, there will be drooping of the angle of mouth. There will be drooping of angle of mouth if this nerve is injured, right? And the most famous personalities whom you must have seen with this drooping of angle of mouth are Sylvester Stallone. I'm sure if you watch Hollywood movies, you must have seen Sylvester Stallone speak. Or you must have, if you follow cricket, you must have seen Jeffrey Boycott. Or if you follow Indian politics, then Sharad Pawar. All three of them, when they speak, they have a crooked face and drooping of the angle of the mouth on one side. And that's because this nerve has been injured in all three of them on one side. So the question arises, how do we prevent injury to this nerve? So to prevent injury to this nerve, the incision should at least be 2 finger breadths below the angle of mandible, right? The incision should be at least 2 finger breadths below angle of mandible. The same point I've highlighted in parotidectomy as well. If you remember, for parotidectomy you have the lazy S incision, and I've told you the same thing, that the incision should be at least 2 finger breadths below the angle of mandible to prevent injury to the marginal mandibular nerve. This was a question, marginal mandibular nerve injury was asked last year in the mid-year AIIMS exam. Okay. Other nerves which can be injured, the spinal accessory nerve can give rise to shoulder dysfunction. Can give rise to shoulder dysfunction. You can have lingual nerve, hypoglossal nerve. If there is a very adventurous surgeon, then the phrenic nerve can also be injured. Okay. So these are the various nerves which can be injured in neck dissection. These you need to know about. The other complications are seroma, that is accumulation of fluid, which is why we put in a drain. There can be flap necrosis. Shoulder dysfunction I've already highlighted for you if the spinal accessory nerve is injured. And the one which is responsible for maximum mortality is carotid artery blowout. So carotid artery blowout, what happens is that once you've done a neck dissection or oral cancer surgery, because of infection or because of saliva trickling out, you know that when you've removed everything, the carotid artery is lying bare. You just have skin cover over it, right? And if there's a small hole which develops there in the carotid artery, it can just blow open and it has a very high mortality rate. I still remember a case which I saw when I was a second year postgraduate in the emergency, and I can never get it off my mind. There was this patient who had oral cancer surgery, and after a month and a half, the patient developed an infection, and when he came to the emergency, there was a huge bulge in the neck, and suddenly it just burst open and there was blood spurting all over. It was hitting the roof, so the entire roof was red, and we lost the patient within 5 minutes, right? So very high mortality rate of carotid artery blowout. Mind you, it is not the most common complication. It is the one with maximum mortality, right? So this was regarding oral cancers. We've discussed the diagnosis, we've discussed the management. I've told you about neck dissection, which is a super important topic for the exam. Now, around 2-3 years, 4 years back, there were certain questions which were asked from dental cysts as well in the Central Institute exams. So I'm just going to briefly cover 2 more points here. One is a dentigerous cyst. Now a dentigerous cyst, it is a cyst in relationship. It is a cyst in relationship to an unerupted tooth. Cyst in relationship to an unerupted tooth. So you can see here that this is the unerupted tooth which is there, and this is the cyst which is formed. This is the cyst which is formed there. This is a dentigerous cyst, right? Mind you, it is an unerupted tooth and it does not have dental caries in it, right? And you can see here on an X-ray. X-ray is how you can diagnose it. You will see a cystic lesion and you will see the unerupted tooth. The management of a dentigerous cyst is enucleation and removal of the tooth, which is the unerupted tooth, and most commonly it involves the third molar. Most commonly this dentigerous cyst involves the third molar. Now in comparison to a dentigerous cyst, you have a dental cyst. A dental cyst is a cyst in relationship. This is a cyst in relationship with a caried tooth. So if you have a tooth which has dental caries and a cyst in relationship to that, that is a dental cyst. It is painful, and on X-ray here the margins will be sclerotic. Here the margins will be sclerotic. That is a dental cyst. So you should know about these 2 cysts. Another tumor which you should know about is an ameloblastoma. This arises from the ameloblasts. The most common site for ameloblastoma is the mandible, and the patient is going to, the clinical features, patient is going to come with a bony hard mass in the mandible. You can see here that there is a swelling, a bony hard mass, and a diagnosis can be made on an X-ray or an OPG. OPG is an orthopentogram. OPG is an orthopentogram, which is a special type of X-ray for the region of mandible and to see the dentation. The management for these patients is excision. You have to excise the ameloblastoma. Okay. and this is usually a benign tumor, so excision is sufficient if you can get adequate margins, and then you reconstruct the mandible after that. Now the final topic in this module, and this topic was asked a few years back in the AIIMS exam, is metastasis from an unknown primary. Metastasis from an unknown primary. So as the name suggests, that you will have metastasis, but you don't know where the metastasis is coming from. So we are talking about Mets to cervical lymph nodes. Mets to the cervical lymph node. So again, let me tell you an example of a patient whom I saw during my residency. There was a 45-year-old man who would come with a 3 centimeter lymph node in the neck, right? 3 centimeter lymph node on the right side of the neck in level 2. So, whenever an Indian patient comes with a lymph node enlargement, the first thing the mind goes to is tuberculosis. There was no other lesion in the oral cavity. We did an examination, oral cavity was clean, we could not see any oral cancer lesion there. So when you get such a patient with an isolated cervical lymph node enlargement, what do? We'll do an FNAC. So we did an FNAC, FNAC is fine needle aspiration cytology, and the FNAC in this patient turned out to be a squamous cell carcinoma. So the patient came back with his report and it was written squamous cell carcinoma. Now, for a moment we were surprised because, we could not see any lesion in the draining area of the cervical lymph nodes. So what do we do here to find the lesion? We know it's a squamous cell carcinoma, so we need to search all the squamous sites. So we need to do triple endoscopy here. The next step in the workup is to do a triple endoscopy. Triple endoscopy will be a nasopharyngoscopy, a bronchoscopy, and an esophagoscopy. Because these are the squamous areas, right? Now supposing it turns out to be an adenocarcinoma, sometimes this lymph node can harbor an adenocarcinoma. So if it's an adenocarcinoma, we will do pan endoscopy. Pan endoscopy will be upper GI scopy, colonoscopy, and bronchoscopy. So we are searching for all the adenocytes which can give rise to METs. Now, the classical description of metastasis from unknown primary is metastasis to a lymph node which clinically and radiologically you cannot determine what is the primary site. Clinically, radiologically you cannot determine the primary site. So sometimes even when you do these scopies, tumors can be missed. Because there are certain blind areas in the oropharyngeal and nasopharyngeal region where tumors can be missed. These blind areas must have been covered by Dr. Manisha and ENT as well, and they're asked quite frequently. These blind areas are floor of mouth where you can miss a tumor. Floor of mouth, you have retromolar trigone, which is the triangular space behind the third molar. You have tonsillar fossa, piriform sinus, and you have fossa of Rosenmuller, which is there in the nasopharyngeal region, fossa of Rosenmuller. So these are the blind areas where a cancer can be missed. So while doing these scopies, we need to be particularly careful about searching these sites. Now you know that these days we have a PET-CT. PET-CT is positron emission tomography. And we use 18 FDG, 18 fluorodeoxyglucose. That is the isotope used to do this whole body scan. And since the advent of PET scan, incidence of unknown primary incidence of unknown primary has reduced. Right, because with the PET scan, wherever the tumor is, it will shine up on the PET scan. Okay. The question which was asked in the AIIMS exam regarding this, let's answer that now. So you have a 32-year-old male who comes with a 2 into 1 centimeter lymph node in level 2 on the left side. Right. On FNAC, it turns out to be squamous cell carcinoma. No primary is found despite extensive search. So we know no primary found. We know it's an unknown primary. And on PET scan also, no distant mets are seen. PET scan also can't tell you sometimes where the primary is, and it shows that there are no distant mets. So what is the stage? Now, T stage, do we know about the primary tumor? We don't know about it. So if we can't assess the primary tumor, we know it is Tx, cannot be assessed. Cannot be assessed. Nodal staging, single lymph node less than 3 centimeters is N1. And M, PET scan shows no distant mets. So they've clearly told you no distant mets. So it is M0. If the question was that PET scan has not been done, so that means I haven't assessed the distant mets, then M would also be X. But here they've said that the PET scan shows no tumor. So M0. So it is Tx, N1, M0. This was the question asked in the exam. Before we wind up this module, let's quickly do 1 or 2 more questions. One is regarding staging of oral cancers. So patient comes with a 3 into 2 centimeter lesion on the lateral border of the tongue on the right side. Okay. So T stage, you know, T1 is up till 2 centimeters. T2 is 2 to 4 centimeters. So T2, on examination, there is a single 4 centimeter lymph node in level 3 on the right side. The lymph node is hard and is adherent to the skin. So single lymph node more than 3 centimeters, less than 6 centimeters, ipsilateral would be N2A. But the catch here is it is adherent to the skin. And I told you adherent to the skin means extranodal extension is positive. And I told you if extranodal extension is positive, irrespective of the size, this is going to become N3B. And no other metastasis, M0. So these are 2 questions regarding staging, which you should definitely know for the exam. All of the following structures are removed in radical neck dissection except level 3 lymph nodes, they are removed, yes. Spinal accessory radical neck dissection, yes, it is removed. Sublingual gland, no, it is not removed. Tail of parotid, it is removed. This I told you was the question asked in the AIIMS exam last year. So this was regarding the module on oral cancer, a very, very important module. Definitely one question in the MCQ exam is asked from this. Okay. For final year students, please go through the case presentation. I have described the examination and the relevant points in history which you need to know. Other than that, you should know about neck dissection. You should know about neck dissection. It comes as a short note. The risk factors and the pre-malignant conditions of oral cancers. The pre-malignant conditions comes as a short note. Leukoplakia, erythroplakia and submucous fibrosis are very important short notes for your exam. So these are all short notes which you need to know, and the case discussion is already there as a continuation of this module. Thank you.